Hello everyone, welcome and thank you for joining us for today's webinar, Assessing and Supporting Reproductive Healthcare Needs and Desires of People Living with HIV. My name is Sarah Simelka. I'll be moderating our webinar today. Today's program is co-sponsored by the Midwest HIV Prevention and Pregnancy Planning Initiative, which is a project of the AIDS Foundation of Chicago, along with the Association of Reproductive Health Professionals. Before I introduce our first speaker, I have a few short housekeeping announcements. All attendees are in listen-only mode. We will not be taking questions over the phone today. However, everyone can submit questions at any time using the chat feature. During Q&A segments, the moderator, myself, will read selected questions that have been submitted through that feature. Here you can see a screenshot showing how to submit your questions. You could also email them to me, Sarah, at the address on this slide. This webinar is being recorded, and afterwards we will be making the recording available to everyone who is listening in. For those participating live on July 12th today, there's the opportunity to receive CNE and CME credits, but to be eligible, you need to be logged into the webinar system for the duration of this webinar, which is scheduled to last for 90 minutes. In addition, you will need to fill out the evaluation at the end. The system will send you a SurveyMonkey link following this webinar, and you'll need to fill that out before receiving your credit. So now I'll be turning things over to Pamela from the Midwest HIV Prevention and Pregnancy Planning Initiative, and she will begin our presentation.
Greetings, everyone. Welcome to today's webinar. We're really happy to have you with us today. I'd like to first of all state that Maggie Castor, who is my co-facilitator, and I have nothing to disclose today. So the Midwest HIV Prevention and Pregnancy Planning Initiative aims to help improve the reproductive health care of people living with and vulnerable to HIV. To achieve this goal, we provide training to clinicians throughout the Midwest on the latest in HIV prevention options, including PrEP, and also ways to meet and affirm the pregnancy desires of people living with HIV. The AIDS Foundation of Chicago launched this project with funding from the U.S. Department of Health and Human Services National Prevention Partnership Award. Today's learning objectives. It is our hope that by the end of this presentation, participants will be able to employ new strategies to meet the reproductive health care needs and desires of people living with HIV, initiate affirming conversations with women living with HIV about their fertility desires as well as their partners, support safer conception for sero-different couples, and facilitate access to contraception and conception care, resources, support, and assistance for women living with HIV. The majority of women living with HIV are of reproductive age. As a matter of fact, 75% of all people living with HIV in the U.S. are of reproductive age. More than 140,000 male-female sero-different couples are known to live here in the United States. While there's been a decrease in new infections among African American women, they still continue to represent a disproportionate number of new cases among women. Many factors contribute to risk and vulnerability for HIV, including unprotected anal sex. It's estimated that 40% of HIV infections among U.S. women with multiple risk factors is linked to unprotected anal sex. Also, providers are not talking with people living with HIV about sexual health and pregnancy planning, which means that they're really missing opportunities to meet the reproductive needs and desires of people living with HIV. People living with HIV do in fact want to know about safer conception possibilities, what their opportunities and options are, as well as the strategies. I want to start this section by grounding our discussion in an understanding of what reproductive rights are. The World Health Organization defines reproductive rights as the basic right of all couples and individuals to decide freely and responsibly the number, spacing, and timing of their children, and to have the information and means to do so, as well as the right to attain the highest standard of sexual and reproductive health. This is the baseline premise for our time together today. When we talk about meeting the reproductive health care needs of people living with HIV, we're also talking about actualizing the reproductive rights of people living with HIV. Reproductive health care is important for all people, regardless of HIV status. For people living with HIV, high-quality reproductive health care optimizes health care outcomes by increasing treatment and prevention of STIs, enables safer conception strategies, and also demonstrates the recognition and respect for people living with HIV as sexual beings. People living with HIV have shared through surveys, individual interviews, and focus groups what they want and what they need from their providers. Some of the things included include access to full complement of high-quality sexual and reproductive health care services and care across their lifespan, including and beyond childbearing years. Building and sustaining healthy families, planning pregnancies and spacing children, as well as knowing about and accessing all available prevention options, which include pre-exposure prophylaxis or PrEP, post-exposure prophylaxis or PEP treatment, and female condoms as well. So people living with HIV also cited that provider-initiated, and I said provider-initiated, conversations with their clinicians about their sexual health experiences, practices, and fertility possibilities is also a need. Discussion of sexual experiences is particularly important as it can create the space to help discuss things such as past trauma. We know that women living with HIV experience high rates of sexual trauma, and asking whether sexual experiences have been consensual or non-consensual can foster a more open dialogue so that clinicians can better meet her needs. So a combination of federal and global health authorities, as well as professional healthcare associations, have released guidelines, recommendations, and opinions stating clearly that people living with HIV should be offered comprehensive reproductive health care services, including preconception care and PrEP. You can refer to CDC's expert panel on the prevention of mother-to-child transmission and see that it offers guidance and recommendations about safer conception strategies. We know that people living with HIV are not getting the health care that they need and want. There are a number of reasons for this, and we're going to dive into that now. There's a number of factors that make it difficult for people living with HIV to get their reproductive health care needs met. Both internal and external stigma, preconceptions, and biases pose significant barriers to accessing high-quality care. Stigma also enables a number of structural barriers, such as discriminatory policies. It also impacts communication between providers and patients. Any one of these factors that we see here can be significant on their own, but they're not standalone, and they actually can reinforce each other. So while these issues are challenging, they're not beyond our reach, and they're not insurmountable. So we have to think in terms of what do we do to break down these barriers. They can, in fact, be disrupted to improve the care of your patients. And yes, eradicating poverty and overturning discriminatory laws does require significant work. But we can all talk about this today and identify ways that providers can take, or steps that providers can take to really effectively minimize some of these factors, including stigma, biases, and also those provider-patient communications, which is very controllable, very doable. So let's take a look at stigma against women living with HIV. In 2008, AMFAR conducted a survey which really helps to provide a powerful and also concerning picture of the American public's view of women living with HIV and their desire and their decision to have children. No other condition inquired about received as low in approval as HIV status. These findings here on this slide clearly and plainly speak to the stigma faced by women living with HIV who desire children. As noted by this quote here on this slide by Steiner, R.J. Steiner, we see that stigma has a profound effect on the ability to plan safe pregnancies and make the scientific advances in HIV prevention real and relevant for the people who need them most. Stigma serves as a significant barrier to HIV disclosure to both partners and providers. Additionally, stigma hampers open discussions between patients and providers, which really makes it difficult to learn about and support the reproductive desires of people living with HIV. Structural issues refers to factors like social and cultural norms, economics, geography, institutional practices, and also discriminatory laws. Examples include HIV criminalization laws, more specifically, the lack of health care insurance or underinsurance, and we know that's a major issue, the absence of providers or the inability to get a provider due to the lack of transportation. The first point here about who wants and should have children is particularly important. Many people living with HIV have been coerced into terminating a pregnancy despite their desire for children and the lack of medical necessity. It's critical to offer non-judgmental, non-directive, and non-coercive advice regarding childbearing. Structural barriers have a reinforcing relationship with stigma. For example, discriminatory criminalization laws were passed due to fear and demonization of people living with HIV, and they continue to perpetuate stigma today and exist throughout the Midwest as well as across the country. So we know that critical conversations are lacking. The Positive Women's Network found that there are few conversations regarding reproductive desires between women living with HIV and their partners. When these conversations do occur, they're most often initiated by the woman, the patient, as opposed to the provider. One study found that age was the biggest indicator of whether conversations even occurred. Women 30 and under were engaged in conversations about reproductive desires 6 times more than women over 30. Regarding men, it seems rare that men of any HIV status are asked about whether they would like to have children and how a provider could support them in building a family should they desire one. So there's a number of factors that result in barriers to effective communication between providers and their patients. Understanding the complex factors that influence what and how patients and providers discuss relevant issues can help us better meet patient needs. So what are the barriers that come to mind for patients? What might be obstacles for providers engaging in effective communication with their patients about sexual and reproductive health? It's important to keep in mind that people who come into your clinics and your hospitals, so all of your medical settings, with a variety of experiences that might impact the ways that they communicate, it's important for that to be kept in mind. And also knowing that this is going to influence what they may be willing to share with you. So some may not have had positive experiences with healthcare providers and systems, and so how might that impact their ability and willingness to communicate to you as a provider? And then ultimately, how might that impact your ability to fulfill their needs and desires and provide them with adequate care? Patients may feel distrustful of both the medical community and the system as a whole. Experiences may leave them feeling wary of being open with a provider. Additionally, it's important to recognize that people living with HIV, especially women living with HIV, may have a history of sexual trauma. Such experiences can affect communication with providers about sexual and reproductive health care needs. So it's important to discuss issues of consent also when discussing sexual experiences. Feeling that conversations about particular topics are outside of the scope of your practice can be a challenge, and then also making assumptions about sexual behaviors and desires based upon their age and gender. So we can kind of assume that some of this sounds familiar to all of the participants today, but what we're asking is that you really keep in mind some of the barriers that might be occurring on both the sides of the patient as well as you as the provider. So why provider-initiated conversations matter? They help to acknowledge people's sexual experiences and their wishes, more specifically sexual pleasure and protection, having children and spacing and limiting children, and then also foster patient-initiated care, reducing stigma, anxiety, and fear, informing and affirming fertility possibilities, and then also enabling inclusion of the partner in the family planning process and assessing and exploring pregnancy ambivalence. So taking a look at assessing and supporting reproductive desires. So as we look at preconception health care, we have to really keep in mind that it's not just for women when we talk about pregnancy planning. And when asked, most people, really see this as kind of a women's thing, right? And so we really have a somewhat narrow scope within our society around preconception health care. Preconception health care applies to everyone in their reproductive years regardless of gender. Whether a baby is desired now, in the future, or not at all, the preconception health care is very beneficial. Why? Because about half of all U.S. pregnancies are unplanned, which of course can result in high-risk pregnancies or engaging in behaviors that one would not have engaged in when planning pregnancy. So prenatal typically starts too late, 11 to 12 weeks into pregnancy, and then also sometimes almost into the second trimester. And we know that this can negatively impact perinatal outcomes. And so preconception health care involves assessing and addressing behavioral, biomedical, and social risks to parental health. Some such health care can involve modifying behaviors, such as improving one's diet, smoking cessation, and other things to help ensure that people living with HIV are at their best and have their HIV under control, and also are on appropriate treatment regimens. So many on the call today are likely already offering preconception health care to patients, but there may be others that aren't and really haven't focused in on the importance of preconception health care for all patients. So taking a look at some topics of preconception counseling for people living with HIV, it's important to cover these following topics, such as HIV disclosure, which is a major challenge. Those of you that currently work with people that are living with HIV know that it's a challenge to disclose one's status. And so this really needs to be at the top of the list when working with patients and identifying what their needs and desires are. Knowing partner status, testing, and readiness for testing, as well as readiness for disclosure of status, whether living with HIV or HIV negative. Also knowing the contraception options and the full availability of those options. Taking a look also at current treatment regimens. Also, what are the risks and benefits of HIV drugs? This is important that patients are aware of. Also, looking at viral load levels and medication adherence. Viral load levels are very important to know during pregnancy and during pregnancy planning, as that can be a major factor in perinatal transmission, transmission from mother to baby, as well as transmission from partner to partner. Also knowing the impact that HIV has on breastfeeding. So we're looking at the full length and breadth of pregnancy planning and the impact. Also perinatal and partner transmission prevention strategies, which is what we address through all of our trainings here at MHPPPI, and then also, as I mentioned earlier, pregnancy spacing. So on the MHPPPI project, we use the one key question to really help us to identify ways to have these conversations, these provider-initiated conversations with patients. And so you see here on this slide a picture of the brochure that we have, and it asks the question, would you like to become pregnant in the next year? And so the one key question, which we know is used across the country, and kudos to all family planning providers that have really applied this strategy, and we love it. Asking about fertility desires, we know, is an important component of HIV prevention. And so providers should ask, again, all people, regardless of their HIV status or gender, if they want to have children in the next year. So these are not, one-off conversations, but really should be asked at every visit as people's desires and life situations change. It's important to be sure not to assume a patient's reproductive desires based upon how the person presents, whether they're presenting as male, female, transgender, etc. So supports are available for individuals and couples that are seeking to have children. And so by asking this one question, you can really help to facilitate these connections. So you can start a dialogue about several sexual health questions by using the one key question strategy. So do you want to have a baby in the next year? It's not just a yes or no question, hopefully, right? This question can be particularly powerful for people living with HIV who may not even know that delivering a healthy baby is possible. So this opens up the dialogue about the many ways in which people living with HIV can substantially reduce their risk for themselves, their partners, and the new baby. It also opens up conversations about current sexual practices, HIV status of partners, and also safer conception strategies. In addition, preconception care, contraception needs and options, adoption, surrogacy, etc. And so we identify this discussion as really being an opportunity to learn more and to do more. So talking with patients who don't desire pregnancy, if a patient says she's not interested in becoming pregnant, find out if she is on a reliable birth control. And this is, of course, also for males as well. So, it goes without saying that you modify these questions based upon the individual that you may be talking with. So asking her about reliable birth control, reminding her of the pregnancy risk when contraception isn't consistently used. Also, it's important to inform patients of the many ways available to prevent pregnancy, and also looking at contraception as being highly effective at preventing pregnancies. As such, it's important for women living with HIV to know about and be able to access the contraception options that best meet their needs and desires. With providers' guidance, HIV-positive women wishing to prevent pregnancy altogether or to space the birth of additional children can find, mix, and use the options that work best for them. So talking with patients that might be unsure. If they're unsure, explore their feelings of uncertainty. Expanding the discussion further to understand their ambivalence will help to hopefully get a better sense of their needs and desires. Using these follow-up questions that we have here on this slide really can help to learn more about a patient's needs and wants. If it turns out that the answer is really yes, a baby is in fact wanted, then moving the conversation to addressing the first steps that person may need to take to make a safe and healthy pregnancy possible would be the next thing that a provider would want to do. And then if pregnancy is not desired, well, discussing contraceptive options including long-acting reversible contraception would be the next suitable step. And so we'll talk a little bit more about that later in this presentation. And then also we have talking with patients who are considering pregnancy. People living with HIV can, again, as I said earlier, have babies, and that's what we're here to talk about, and have healthy babies. With proper medical care and support, perinatal transmission can be reduced to less than 2%. Helping your patient understand this is incredibly powerful as it reduces their anxiety and helps them to understand the new possibilities that may have previously been unknown to them and unknown to some providers. So at this time, I'd like to hand the mic over to Maggie, and Maggie's going to go further into preconception healthcare services. Thank you.
Wonderful. Thanks, Pamela. All right, so above is a list of the preconception care services that comes from the CDC. It's important to note that these conversations about preconception health should occur on an ongoing basis with both men and the women that you see. So as more than half of the pregnancies in this country are unplanned, it's critical to include both preconception and contraception conversations and care into primary health care visits. Next slide. So the basic recommendation, the actions are the same for people who are either desiring pregnancy or are okay with pregnancy occurring regardless of HIV status. Each service is relevant for people of any gender in addition to what is listed. Preconception health actions include stopping smoking, consuming alcohol and drugs. Men should decrease these, and talking with the provider about safety of prescription medications, starting folic acid or prenatal vitamins for women, eating healthy and exercising, and ensuring that immunizations are up to date. So in addition to the recommendations for people of any HIV status seeking to become pregnant, there are a number of different steps that must be taken to support women living with HIV who do want to become pregnant. First and foremost, we want to check their viral load. If she does not have an undetectable viral load, then we want to delay getting pregnant until HIV is completely under control and suppressed. So we want to assess the CD4 count. If they have a CD4 count of less than 50, then they may have trouble becoming pregnant as they're very immunocompetent. So to enable the best health outcomes for the mother and baby, we want to work to achieve an optimal level of health before attempting to become pregnant. We want to determine if her current antiretroviral regimen is safe for her pregnancy and if medication may be needed or if the ARVs need to be changed in order to have an appropriate safety profile for delivery and pregnancy, and one that has at least one drug that crosses the placenta to help provide protection. We want to ensure to evaluate and manage any side effects that may be occurring as a result of the treatment regimen. So it's important to make sure that the side effects like hyperglycemia, anemia, and hepatotoxicity, which can negatively impact the maternal and fetal health outcomes, are effectively managed, as well as if mothers are having nausea with the regimen, there's many things that we can do like Zofran and things like that to ensure that they are still taking their antiretroviral regimen daily during pregnancy. Next slide. Preparing for a healthy pregnancy involves assessing the readiness of the partner as well. This involves talking with the partner about their preconception plan, as well as screening them for HIV. If their HIV status is unknown, as well as testing and treating them for sexually transmitted infections. If the male partner is HIV positive, it's important that he also be virally suppressed. Because ARV treatment may be associated with a higher prevalence of semen abnormalities, such as low sperm count, low motility, higher rate of abnormal forms, and low semen volume, it's recommended that a semen analysis may be conducted. This is a fairly cheap test, so it's something that we can definitely do in order to help them get pregnant. Next slide. So we're going to talk about safer conception strategies. Having a negative family can be the most positive thing in a person's life, and with the use of safer conception strategies such as treatment as prevention, using Preconception, and other strategies, this can happen for people living with HIV and their partners. So above is a picture of Andrew. He's from Phoenix, Arizona, and has been HIV positive since birth. His parents died from AIDS. However, he was the only one of his siblings to be diagnosed with the illness. Andrew and his wife, Victoria, conceived their first child using fertility treatments, but conceived their second and third children naturally. The 33-year-old's viral load is classified as being undetectable. Next slide. So we know that viral suppression is important for both the person living with HIV health and for reducing transmission. We know that taking HIV medications for prevention is a safe and effective way to reduce onward transmission of HIV and opens up new possibilities for families building families for people living with HIV and serodiscordant couples. These new prevention options play a critical role in helping HIV-impacted couples achieve their reproductive desires. The HBTN study in 2011 found a 96% reduction in HIV transmission among heterosexual couples compared to those not on antiretroviral therapy. The partner study in 2014, which included straight couples and gay men and other MSM, found that there was no HIV transmitted in a person that had a viral load below 200. So it's very important that people are taking their antiretroviral regimens, taking them daily at the same time to achieve that suppressed viral load. As the partner study in 2014 showed that even a viral load less than 200 people were not transmitting it. Next slide. So why is the use of PrEP important for pregnancy? First, it's important to note that a woman's HIV susceptibility is higher during her pregnancy. Perinatal transmission is higher when HIV is acquired during pregnancy or lactation. So clinical studies show that acute, newly acquired HIV infection puts both mother and baby at even greater risk than chronic HIV, even if it's untreated chronic HIV. There was up to a 15-fold increase in perinatal transmission compared to a 4-fold increase in lactational transmission. Next slide. So with PrEP, we want to start daily doses 1 month before the conception attempt, and we want to continue daily dosing until 1 month after that last conception attempt. Now, sometimes we have them take PrEP throughout their whole pregnancy, and that's just going case-by-case basis to determine what's best for the couple. Next slide. So the expert recommendations show that PrEP should be offered during pregnancy and lactation, and that we should discuss with them the benefits and risks. PrEP has reassuring safety profile, and so we just want to make sure that providers are talking to moms and letting them know that we want to be vigilant to prevent transmission during the breastfeeding period as well. Next slide. Providers should discuss the following with couples. We want to talk to them about the potential risks. We want to talk to them about taking PrEP every day at the same time. We want to talk about continuing to use condoms after conception to reduce STI and HIV risk. We want to talk to them about the signs and symptoms of acute HIV infection and when to come in for a test. We want to let them know that there's an urgent need for HIV infection when it is suspected. And then we want to discuss the pros and cons of staying on PrEP after conception. So determining what is best for the woman at this time to see if they can use condoms, or if her risk is perceived to be higher, then we want to keep her on PrEP during pregnancy. And it is considered safe during pregnancy and lactation. Next slide. Most babies who contract HIV do so during the labor and delivery process. So providers should discuss the labor plan with their patients. It's important that the woman bring her HIV drugs with her to the hospital, particularly if she ends up delivering in a hospital other than where she was registered. And some hospitals don't always carry the HIV antiretroviral therapy with them. Or at the hospital. Some hospitals don't stock it, some that are out of county, things like that. So it is important that we remind these women to bring their medications so that they don't miss a dose. And if their dose is due while they're at the hospital, then they definitely need to take their medication so that they don't miss it during the labor and delivery period. Vertical transmission of HIV is less than 1%, providing that the expectant mother is receiving care by an appropriate medical team. So this includes an OB for prenatal care and an HIV specialist. When appropriate, we do involve mental health and drug abuse treatment services. The expectant mother is adherent to her antiretrovirals and has an undetectable viral load by delivery, but preferably that viral load is becoming undetectable as early in pregnancy as possible. So when infection does occur, it is generally during the labor and delivery process or the peripartum period. So in the utero, the placenta produces protection against HIV molecules as they're too large to cross the placental barrier, thus offering protection from infection. But during the labor and delivery stage, the membranes rupture, or the bag of water, which also acts as a defense mechanism against bacterial infections for the baby. So when the membranes rupture, that defense is now gone. So studies indicate that the risk of the baby being infected increase as the length of time the membranes are ruptured and with each vaginal exam. The baby makes its way through the birth canal in an environment where blood and secretions carry HIV. So if the viral load is high and antiviral medication is not provided to mom and baby, transmission is of great concern. Breastfeeding further decreases this transmission an additional 8 to 16%. However, we don't know the transmission rate for women with an undetectable viral load. So in the United States, our guidelines continue to recommend that women living with HIV do not breastfeed their babies. We say formula is the safest, and so we want to bottle feed these babies, and this is the education that we currently give our mothers. Next slide. Antepartum transmission. While most perinatal transmissions occur at labor and delivery, infection can also occur in the antepartum or transplacentally. In utero, HIV transmission typically occurs when a woman contracts HIV during her pregnancy, as the viral load during acute infection is also very high. Also, women not taking antiviral meds, or those who have a high viral load or contract other STIs, are at all increased risk of transmitting during the antepartum period. So infections can increase the transmission. These certain infections can be placenta abruption or chorionitis. These result in an inflammation or placental breakdown and allows transplacental transfer of HIV to the fetus. These are all reasons that the mother could benefit from receiving IV AZT during labor and delivery. So the new guidelines state that you can forego intrapartum AZT if the woman has a history of a less than 1,000 viral load and she's retained in care. So the most recent viral load, it takes a couple days depending on where you're at to get that viral load back. But if we can get it late in pregnancy, and if she's less than 1,000, then you can forego the IV AZT. Although a lot of providers still give the IV AZT as it's that added protection to mom and to baby, and there's no side effects that occur when we're giving that. Next slide. So we want to consult the clinical guidelines for considerations on the latest and recommended regimens for pregnant women. We want to support their retention and care so that we can achieve an undetectable viral load. We want to follow the PACTG 076, which tells us to give 4 hours of AZT to the mother until the cord is clamped. Then we want to administer AZT to baby for at least 4 weeks. Now, for high-risk mothers in labor and delivery, it changes a little. If the woman is not adherent or has an unknown viral load, or the viral load is above 1,000, then we need to have a C-section scheduled at 38 weeks. An IV AZT should continue to be administered to women living with HIV who have a viral load of less than 1,000, and the baby should receive triple therapy per the DHHS guidelines. Women should not breastfeed, and counseling should be provided to mom to prepare for questions due to cultural family practices. It's important to note the sociocultural issues regarding breastfeeding for many women. For some women living with HIV, the decision not to breastfeed raises concerns that others will know their HIV status, that they will not enjoy as strong of a bond with their babies, or that their baby will not be as physically well. So we want to encourage moms. We want to tell them that by bottle feeding, you can have the rest of the family help. If they have a partner, if they have siblings, they can help feed the baby. It can also be psychologically difficult for women who see breastfeeding as an integral to their identity as a mother. Providers can help allay some of these concerns and ensure the woman has the support she needs to do bottle feeding replacement. So for example, I had this woman who was from Africa, and she had just moved here a year ago, and she recently found out that she was pregnant. And when I told her that she wasn't going to be able to breastfeed this baby, it was very hard for her. And so we think back to her cultural norms. In Africa, they're still told to breastfeed their babies when they have HIV. And she was telling me how her daughter didn't turn out HIV positive and why she can't breastfeed during this pregnancy. So you'll have some things that do come up that you do want to talk to patients about and reassure them that formula is best. As we're living in the United States now, there's more access to formula. We try and get them hooked up with the women, infant, and children's services and things like that. So it's very important to definitely educate early on in the pregnancy about this so we can continue to provide them resources and education to confirm that they will bottle feed after delivery. Next slide. So PROMISE is a study that it's a multi-component study that aims to determine how best to safely reduce the risk of HIV transmission from women living with HIV to their babies during pregnancy, delivery, and after childbirth, while preserving the health of both the mother and the child. Next slide. Low-risk mothers in labor and delivery, they do not need the IV AZT like we were talking about earlier. It's not required for HIV-infected women receiving continuous antiretroviral therapy with a viral load of less than 1,000 in late pregnancy or near delivery, and for whom there are no concerns about adherence or tolerance to the regimen. However, many clinicians still do administer, and then the baby still receives at least 6 weeks of the baby still receives at least 4 to 6 weeks of the AZT. If the viral load is less than 1,000 or even undetectable, sometimes they forego the IV AZT, but the baby still receives the 4 weeks of AZT after they're born. We want to err on the side of caution as this doesn't provide any harm. So traditionally, AZT given for 6 weeks combined with 3 doses of nevirapine, and these 3 doses occur at birth, 48 hours later, and 96 hours later. And these are begun as soon as possible after birth. And this is for somebody who has a high-risk exposure to the newborn. But some experts do recommend the triple antiretroviral prophylaxis for infants at a higher risk of acquisition, although there is no data demonstrating improved efficacy for a 3-drug regimen over the 2-drug regimen in transmission or prevention. So it depends on the pediatrician. If the membranes rupture in a woman who does have a C-section scheduled due to an increased viral load of less than 1,000, then it's no longer certain that there's any benefit to perform the C-section, as exposure may have already occurred. Pregnant women with a high viral load need 3 hours of intrapartum AZT regardless of vaginal delivery or C-section. Babies born to moms at high risk will also receive a 3-drug regimen. Next slide. Natural childbirth is always recommended when it's an option. Research tells us that there's no increased benefit for a woman to have a C-section when her viral load is less than 1,000. C-section is a surgery, so it has risks, including increased chance of infection. It also requires more healing time. Next slide. Pregnancy spacing is important for both maternal and child health. In addition to giving the body a chance to heal, it also affords the opportunity for the parent to offer greater time and attention to the baby during its first years, which is important to their development. Next slide. So there's risks for having back-to-back pregnancies, both for mom and for baby. For mom, there's increased risk of uterine rupture, inflammation of the genital tract, additional stress on the immune system, anemia, and economic challenges. For baby, there's risk for low infant birth rate, increased risk of premature birth, increased risk of health problems throughout life, and undeveloped lungs. Next slide. So now we're going to dive into hormonal contraception and women living with HIV. Next slide. Most hormonal contraception is safe and recommended for women living with HIV. There's interactions between the hormonal contraception and antiretroviral drugs that compromise hormonal contraception efficacy. It is possible, but for example, there's several NNRTIs and protease inhibitors that may reduce contraceptive efficacy and may increase adverse effects. However, it is unknown to what extent drug level changes compromise this contraceptive effectiveness or increase adverse effects. Sometimes we need to increase the amount of estrogen in our OCPs, secondary to the antiretrovirals, but we really look at what antiretroviral they're taking to see if we do need to increase the estrogen dose. But providers should check the clinical guidelines to see if any drug-drug interactions have been identified between the patient's HIV regimen and the desired hormonal contraception. And if interactions are known, alternatives may be recommended. It is important to note that interaction concerns should not prevent hormonal contraception prescriptions when patient preferred. Next slide. As with all patients, we want to begin conversations on contraception with the most effective method, which is LARCs, or long-acting reversible contraception. Next slide. Recent analysis confirms that there's no increased HIV risk with oral contraception. Limited data indicates that there's no increased risk with the use of levonorgestrel implants. No data is available on the etonogestrel implants, and the latest data suggests that the NET-N does increase HIV risk. No data currently exists on hormonal contraceptive rings, patches, and IUDs in regards to HIV risk. So in summary, more research is definitely sought. The ECHO trial, or Evidence for Contraception Options for HIV Outcomes, aims to examine whether Depo-Provera, NET-N, which is an injectable, or Jadel, an implant, and the copper IUD device result in higher HIV risk. Women would need to be randomized into one of these arms to receive one of these long-acting reversible contraceptive options, but all the options are hormonal except the copper IUD. There's a debate on whether the trial should be conducted, and the opponents contend that the resources to conduct the trial should be investigated at the country level to expand method mix and move away from Depo. Supporters say that without the trial, questions regarding risk will still persist. Next slide. The bottom line is we need to educate our patients about the importance of contraception for pregnancy prevention and spacing. We want to make sure we talk to them about what is known and unknown. We want to listen to their concerns and context and ultimately let them decide what option is right for them after giving them all the information that we know. Next slide.
Okay, thank you so much, Maggie. And I wanted to make sure that everyone's clear that Maggie is available right now for questions. So please be sure and type in your questions to us. This is a wonderful opportunity for you to think in terms of, well, what do I really want to know about HIV prevention, pregnancy planning, sexual reproductive rights? This is the opportunity to really engage with us in intimate conversation about this subject matter. We will be on the call on the webinar until 1:30, so we're available to you right now. As with most clinicians, and you all know this, Maggie is a very, very, very busy person, but we really want you to lean on her expertise today during the webinar and go ahead and start sending in those questions. We've got a couple, but we really want to get more than just 2 questions, okay? So please get those in. So now I wanted to share a few notes about national resources. Keep in mind that it's not important for you to know all the answers. No one has all the answers. And so we've got folks available across the country in many different ways available to you. So let's take a look at the Clinician Consultation Center. That's out of UCSF. And so we have the link here, but we also have a telephone number, 888-448-8765 that you can call with questions. And then also the Illinois, this is state-based, so we are here in Illinois, of course, the Illinois Perinatal HIV Hotline. They are wonderful. You see the link there as well, in addition to 800-439-4079. It is so important that you lean on the expertise of others who might be able to support you and provide you with detailed information that you might need.
And this is Sarah, also just chiming in to say that, yeah, that is the Illinois Perinatal HIV Hotline, but they do have connections across the country, and they will refer out. So if you do not live in Illinois, you can still call that number, and they will likely be able to connect you with someone because they have great connections all over.
Thank you so much, Sarah. We also have here on our next slide more national resources. You can check, you can share your questions and go through these checklists and protocol sheets, etc. This is a wonderful resource. And so we have the FXB Center on Preconception Care for Women Living with HIV. So you've got two links here that you can access information. We've got HIVE out of San Francisco. They have a lot of information. They're one of our strongest partners in the work that we do. HIVE has positive and reproductive health, sexual health information, and if you visit their website, you're going to see all kinds of good stuff, so please be sure and visit HIVE. Also, information on One Key Question, which we're really grateful to them for allowing us to use some of their information for our brochure, and so you can read further on the One Key Question strategy there at that link. In addition, and yes, the slides will be provided. I wanted to make sure that everyone's clear on that. And then also there's the National PrEP or Pre-Exposure Prophylaxis Locator link, which is preplocator.org. And we also have a PrEP locator for those of you that are here in the state of Illinois through the Prep for Love, right? The Prep for Love campaign. And so also check and see what resources you have locally. There are a lot of campaigns rolling out across the country specific to pre-exposure prophylaxis, but you also have other campaigns around STIs and pregnancy planning and perinatal care. So really gather all the resources and support that you possibly can to help help to ensure the best delivery of care services for women and their partners around HIV prevention. So then on this next slide, we've got MHPPPI, and remember this is the Midwest HIV Prevention and Pregnancy Planning Initiative. We have our resources on our website. We know that a lot of you have already checked out our website, but for those of you that haven't, we're at www.mhppi.org. That's MH3Ps and the I.org. We have links to videos, resources, clinical guidelines, brochures, postcards, training, slides, etc. And so we want to make sure that you get in touch with what we have available as well. And our website will also provide you with links to other websites, including HIVE out of San Francisco. And also we have brochures, postcards. You see our next slide there. And then also information on how you can contact me, Tassin at aidschicago.org, to order resource information, and then also to access our team. And on our next slide here, we have our acknowledgements, the work that we've done over the course of our funded project really couldn't have been done without our partners, and so I want to really give a warm shout out to ARP for not only co-facilitating and co-hosting our webinars, but also for their engagement with us around providing continuing education. ARP, you've been wonderful, and thank you. We really want to make sure that everyone in our audience today is using MHPPI and ARP and reaching out and getting the supports that you need. So at this time, we're going to take a look at the questions that we have. So I'm going to turn it over to Sarah.
Hi, thanks for everyone who is sending in questions. I'm getting those and kind of filtering through. Please feel free to keep sending them. We do have some time, and Maggie is still with us so that we can use her expertise. So one, I'm just going to start at the top here. So are there resources and or information on the safety of PrEP being used with hormonal contraception? Maggie, I think you are unmuted if you want to chime in on that.
Thank you. So I apologize. The question was if there's
so are there,
PrEP and OCPs.
Yeah, if there's resources or information on the safety of PrEP being used with hormonal contraception.
So I'm going to be 100% honest, and I don't know if there are research studies out there. I do know that Truvada is considered safe with OCPs, but I do not know that there are any current research studies out there. That's a great question.
Yes, I would obviously defer to Maggie on that, and we can look for that. I do know that when we talk, in our trainings that we do here through the AIDS Foundation of Chicago, when we're talking about PrEP, we do say that it is safe to be on PrEP and a hormonal contraception. So I don't know if there is specific research being done on that, but that's something that we can definitely ask our experts here. We have, again, some trainers and some experts, and we can respond back to everyone through email that has participated in the webinar, but that's a great question. This is another one that's not really specific to reproductive care, but it's something I think it would be good for us all to know. The question asker says, are there resources for getting someone moved from PEP to PrEP?
Yeah, so there aren't specific resources. I'd be happy to talk with that person in more depth, but no. So there is a bridge that we can just go. So after the 28 days of PEP, we can bridge directly into PrEP, so they would just start the Truvada pill on that next day. And so a lot of people bridge very easily. With the last webinar we did, we talked a lot about bridging from PEP to PrEP, but as long as you have that negative HIV test at 28 days, then the next day they can go ahead and either discontinue their raltegravir or discontinue their dolutegravir and just go ahead and start the Truvada dosing 1 tab by mouth daily at the same time.
Great. Thank you, Maggie. So here's another one. It's kind of going back to breastfeeding and the issues you were talking about before. So here's the scenario that someone typed in. If a woman's viral load is suppressed and she's on ARV and she wants to breastfeed exclusively for the first 4 to 6 months, why are we discouraging her?
Oh, if she's on PrEP?
Nope. Her viral load is suppressed.
Oh, okay,
she's
sorry.
on ARV, and she wants to breastfeed exclusively for the first 4 to 6 months. Why are we discouraging her?
Yes, because we do not know, there's not enough research showing that even if you have a suppressed viral load, we don't know how much of the virus is being excreted in the breast milk. So undetectable is less than 20. So we don't know anything less than 20 if any of that is being excreted through the breast milk. So there's just not enough studies that show that right now. So the safest thing to do to 100% prevent transmission is to bottle feed that baby. It's a good question, and I definitely think more research needs to be done, because if we can let these women breastfeed, and that would be the safest thing for them. But right now, unfortunately, there's not enough research, and so we need to bottle feed these babies to prevent transmission 100%.
Gotcha, and that really does address this other question. I'll just read it to you, but I think it's really the same issue. It says, if the mom has a low viral load and the baby is given ARVs during and after delivery, is there still a risk if mom breastfeeds? And it seems like what you're saying is yes.
That's correct.
Okay.
And we don't know the risk. We don't know. So what if mom in the postpartum period forgets a dose one day and then she's still breastfeeding? Or say she, is completely 100% adherent with her medication, but you're undetectable, which is less than 20, but say you still have 10 copies per milliliter of blood. What if one of that gets to baby? I don't think as a provider, if I said it was okay to breastfeed and that baby did get HIV, I would ever feel comfortable with that decision.
Thank you. So here's another question we had come in. Are there considerations for women living with HIV who want to terminate their pregnancy? Are there special considerations for women who want to choose a medical abortion?
No, so we would look at them the same as we look at someone without HIV. We want to, look at their blood type and things like that for a medical abortion to make sure that they don't need any other medications. But if they wanted to terminate for reasons of their own, I mean, if it was because they were worried about HIV transmission, then I would definitely want to counsel them at length about how we can do things to prevent transmission. And over 99% of births, they're not transmitted unless, and there's things that we can do, like starting them on antiretrovirals and education. But if it's for, personal reasons that they wanted to terminate and not just because they had HIV, then no, there's no special considerations that we would need to do.
Great. Thank you. I want to remind people that they can still, if something is popping up in your mind, feel free to ask, type in the questions through the question feature. Another question that we have, so if a woman, potential mother, someone who's looking to get pregnant, is HIV negative and her partner is undetectable, does she need to get on PrEP as they're looking to build their family and to get pregnant? Like, if the partner is undetectable, is that a requirement, or what are the considerations there of
Sure.
the mom who is negative getting on PrEP or not?
Right, so there are no requirements. So if the partner is positive and they're undetectable, then the risk of transmission is very, very low. Like we talked about in that partner study, that if they had a viral load of less than 200, they weren't even transmitting HIV. So, but that's the risk that the woman would have to assume, that, is my partner taking his medication every day at the same time, and is he still undetectable? So it's, educating both the partner and the patient, are you going to continue to have a suppressed viral load and take your medication? And some people choose that they don't feel like they need to be on PrEP because their partner is taking their medication every day at the same time. They've had a suppressed viral load for years, and they feel comfortable getting pregnant. But some women take that extra precaution in pregnancy and use PrEP to conceive, and then they'll just use condoms the rest of their pregnancy. But it's definitely a conversation that you would want to have in the office with both the patient and the partner to see what works best for them. But it's not a requirement to be on PrEP.
Gotcha. Thank you for your thoughts on that. Another question is, and this is for Pamela or Maggie because it's more of on the conversation end, but what tips do you have for supporting women living with HIV around disclosing their HIV status? Has that ever come up before, or yeah?
I would.
Sorry, go ahead, Pamela.
Oh, no, go ahead, Maggie.
I'm sorry, about women telling their HIV
so the
status?
question is, what tips do you have for supporting women living with HIV for disclosing their status? So I'm assuming it's to a partner, a sexual partner, or a partner that they're living with their family, perhaps. Maybe a woman has, whether she's pregnant or not, but maybe she's gotten pregnant and she now needs to tell her family, she feels like she needs to share her status. What are some tips for supporting?
Yeah, so what I have had a lot of new diagnoses in the last 2 years, and I feel like what I really hone in on patients is it's in a very emotional time for them. So what you want to tell them is that you have to choose the right people to disclose your status to, because you don't want to tell somebody and then it wind up in the wrong ears and your status spreads to people. So I always say, if you trust a person, if you love that person, if you want to have sex with that person, you have to tell them. Well, in Indiana, we have the duty to warn here in Indiana, so you have to let them know of your HIV positive status before having sex with them. So that's what I always educate patients on. So, it helps people build relationships. So yes, you can kiss, you can cuddle, you can go on dates, you can, share drinks, share food, but you really want to get to know that person before disclosing the status. And I've had some people even come into the office where they're like, hey, can you help me tell this person? And so that person usually in the past has told them, going into the appointment, I have HIV, but we're going to go so that you can ask any questions that you need to, because there's still such a large stigma about HIV. and it's really sad. So we want to break that stigma, and we want to, help these people in disclosing. So I think support groups are great. We have a bunch of we actually have a women's support group at our hospital, and I know that that group has been really encouraging to other women about disclosing their status, just because they can see how these women disclose their statuses and who they disclosed it to. Is it, close friends, close family members, loved ones, things like that. So I think it's different with each person, but I really stress to my new HIV positive patients about really being careful about who we disclose it to. And when you're dating, going out on dates, getting to know that person to see if a relationship's going to develop where you would want to disclose that status, or if it's not worth it to them.
Great. Thank you, for those examples. Maggie, do you have anything to add, Pamela, about supporting during disclosure?
Well, I definitely would encourage providers to really work in collaboration with case managers and counselors in the area of disclosure. This is a part of their area of training and expertise as well, and so helping them to connect with partners and family members and helping them to identify the best way to disclose, and being there for them. There are things that a clinician may not necessarily be able to do within their area of expertise, or as we look at time. But this is a part of what those counselors and case managers are really trained to do, and so hopefully they can be a part of that process as well. So I would say also look outside to others that are a part of the care and preventative support for people living with HIV.
Great. Thanks, Pamela. And this could be, for Maggie or Pamela, whoever wants to chime in. But if you could share some of your thoughts on taking women off of PrEP after successful conception. So if they, as Maggie said earlier, if your partner is undetectable, PrEP is not a requirement. That might be something you want to consider if you don't know their status, for example. But let's say you did, for whatever reason, you did use PrEP to conceive. What are your thoughts on taking women off PrEP after successful conception?
So I think that it's totally patient dependent. So after a woman conceives, I think that we have to talk about her risk. So if partner is not undetectable, or if she has multiple partners, or if she's at continued perceived risk, then I feel like that patient needs to stay on PrEP because it's the safest thing. Now, if they have one partner who's been undetectable for years and there isn't a risk, then I feel like it's fine to take that patient off. But I feel like it's patient by patient case to determine whether they need to stay on PrEP or take the patient off PrEP. I mean, there's no harm in staying on PrEP during pregnancy. Truvada is a Category B drug, so we don't worry about that. But a lot of women don't want to take anything during pregnancy, and so I would just talk to that patient about what they feel like is best.
Anything to add to that, Pamela, or?
No, nothing to add.
Okay, great. Thank you, Maggie. And I think that actually we've worked our way through the questions. If anyone did have any other questions, you can use the chat feature or the question feature to send those to us. And so I'm just going to scan through really quick to see if there's any extra or any more coming through. Pamela, any kind of wrap-up comments or anything like that?
Well,
or
actually, I do. I
okay.
wanted to, well, the question regarding, and I maybe needed to get some clarity as well, but the question earlier regarding what I believe was safety and the use of PrEP with hormonal contraception. There are two studies, Partners Prep and then the FEM Prep study I would say, are two studies that would help us to get to the outcomes around effectiveness and safety. And so what we can do is send that information out to you, because it's a little bit of reading, but ultimately the safety profile based upon those studies for using PrEP and hormonal contraception was very good. In addition to the effectiveness in comparison to placebo, showed no difference in effectiveness. But I want to make sure that everyone's able to read these studies, because there's still work going on. The clinical trials continue because, as Maggie mentioned earlier, we need more data as it relates to treatment and contraception and breastfeeding. And so unfortunately, we don't have nearly as much accessible as we would like. So we're working with what we have thus far. So again, the FEM Prep clinical trial as well as the Partners Prep clinical trial both showed a good safety and effectiveness profile. However, I think it's important as clinicians to read through these clinical trials and be able to decipher based upon what you see there as a clinician. So we always redirect back to clinical trials and research when necessary, as well as the guidelines, which are based upon the research studies. And so we can make that available as well. We'll provide that link to participants today. So I wanted to add that in there.
And we actually, this is Sarah again, and I just have one other question that just came in for Maggie. I'm just going to read it because I'm not really familiar with the drugs that are mentioned in the question, so I'm just going to read it, and hopefully you can help us address this. And if not, we are, again, like I said, we are also available to do email follow-ups with folks if there's some specifics that we don't have right at the top of mind right now. But I'm going to go ahead and dive into this question. So the question asker says, the only drug interaction of concern that I'm aware of is efavirenz, oh boy, I butchered that, efavirenz, and ENG/Nexplanon. I don't know of any other clinical evidence of failed contraception. The progestin is responsible for the contraceptive efficacy, not the estrogen. So why are you encouraging increasing estrogen exposure?
Sure. So there are some antiretrovirals that do decrease the effectiveness of birth control pills. I'm going to be honest, I'm super spoiled in our clinic that I have two pharmacists who work hand in hand with me, so I always review what antiretroviral regimens they're taking and compare them with any of the birth control methods. And I just know in the past we've had to increase estrogen doses in a couple of them. I always refer to the guidelines though. So if ever in doubt, we always do drug interaction checks at every visit, and then I refer to the guidelines to see what the most appropriate management regimen would be. But yes, that is one, correct. But not, and I want to clarify that not all OCPs need to be maxed out on estrogen. You just have to look at the specific regimen and then pick the correct birth control method from there.
Oh, great, thank you so much, Maggie. And another question too, and I think we might have this at the end, but is it all right, Maggie, if we give your email address or people can email you if they have further questions on this kind of specific?
Yes, that's perfectly fine.
Okay. And like I say, I don't know if that's on one of the slides. It's not. So can you just would you be comfortable giving your address, Maggie?
Sure. It is Margaret, M-A-R-G-A-R-E-T, period, Castor, C-A-S-T-O-R, at Eskenazi Health, ESKENAZIHEALTH.edu.
Great. And I am going to quickly here put this in the I'll send a message via the chat feature to the entire audience with your email address. I'll do that in a moment.
Wonderful.
Yeah. Okay. I think so. I think that's the last question that we had. Maggie, did you have any closing remarks?
No, thank you for this opportunity.
Great. Well, thank you again to everyone participating. And yeah, I said we will we'll send out Maggie's contact information if anyone wants to follow up with her, and then we can wrap it up for today. So just wanted to say thank you again for everyone for participating. To our panelists, Maggie, Pamela, to the Midwest HIV Prevention and Pregnancy Planning Initiative, and especially the Association of Reproductive Health Professionals for co-sponsoring this with us today. This webinar has been recorded, and we are going to be posting this on MHPPPI.org. We are also going to be sending out the slides to all of the people that have registered and participated today, and they'll also be available through ARP, the Association of Reproductive Health Professionals. So the last quick thing is to say there's going to be a link to a short evaluation form that's going to be sent to all participants right after this webinar. It would help us immensely if you would fill that out. So please do take it. It's a short survey. It really helps us improve our trainings and our webinars. It also, if you're seeking credit, that's a requirement as well to fill that out. So thank you again for your time. We hope you have a great afternoon, and thank you for tuning in today.